So milestones, challenges, and the way forward. These are my potential conflicts of interests. And so the question is, do we need precision radiotherapy? Well, the simple answer will be yes, but why? Well, the precision has roots in the basics of radiotherapy. So it's been what we kept challenging from the day radiotherapy was born. So to pursue precision in radiotherapy is simply pursuing the development of radiotherapy. So what is precision radiotherapy? Well, there is no concrete definition of precision. So you can do precision radiotherapy with conventional Linacs, well, newer Linacs. Of course, 3D image-guided brachytherapy. Of course, you can use dedicated machines like the Radizact or, of course, particle therapy machines and type like dedicated machines like CyberKnife also. You can get a very good dose distribution, as you can see here in an SBRT of the lung or IMRT to the prostate. Or image-guided brachytherapy, or image-guided adaptive brachytherapy. And of course, particle therapy. So, radiotherapy 101. Effect and side effect only occurs where it has been irradiated, and effect is dependent on the absorbed dose. Hi there. And this is a very, very nice picture here. Obviously, this is a head and neck radiotherapy case, and you can see the dermatitis here. You can see the dermatitis here. And when you superimpose the surface dose, the severity of the dermatitis is correspondent to the actual dose. So where you have high dose, you have a severe dermatitis, and where you have low dose, not as much. So radiotherapy itself is a very effective tool without any CT simulators, as we all know. This is a very old 2D planning for prostate cancer, and it was okay. Well, it wasn't the best, of course. With the CT simulators, yes, it got a little bit better. But when you look at these two dose distribution, it's not all that different. And also 3D CRT, depending on skin markers and occasional EPID image, tend to have a 1 to 2 centimeters, or even 3 centimeters or more for extremities margin of error. So we were sort of smothering the edges of the dose distribution. That could be in favor of our patients, and sometimes it wasn't. So this is a very, very iconic trial done and published in 1997 with prostate cancer, where we had a very low outcome, a bad outcome with 67 gray or lower, but a very good outcome with 77 gray or higher. More dose to the tumor equals better control. But at the same time, compared to 70 gray versus 80 gray, we have a very elevated risk of grade 2 or severe rectal toxicity. Less dose to the normal tissue, obviously, leads to less toxicity. So, since effect and side effects only occur where it has been irradiated, what if we can irradiate only the tumor and not the normal tissue? And since effect and side effect is dependent to the absorbed dose, what if we can escalate the dose to the cancer itself and keep the dose to organ at risks minimal? Well, tighter margin is the natural answer. And this is where precision radiotherapy comes in. So back to the basics again. So when we talk about the target volume delineation, we first have the gross tumor volume, which we all contour. We can't do anything about that. All we can do is to contour our GTVs very carefully. You can say that is even more so with the CTV. Every pixel you draw as a CTV, it potentially can worsen your patient's quality of life. And every pixel you don't contour as a CTV could potentially lead to the marginal recurrence of your patient. So this is a very, very difficult dilemma we have when we are contouring. So then we have the ITV, which adds internal motion margins to the CTV. This is something what we can alleviate using a lot of techniques. We should. And finally, we have the PTV, which is setup margin plus ITV plus setup margin. So this is another area we can ideally eliminate, but practically it's impossible to completely eliminate, but at least we can minimize this. Okay, so one thing is respiratory gating. This is an attempt to reduce the required internal ITV margin. So this technique actually outdates or predates IGRT. Really interesting. Was first proposed in the late 1980s. As you can see, the tumor here in the exhale phase can be visualized here. This clearly stated the need of respiratory gating in radiotherapy. Now, actually, this technique, the respiratory gating technique, was initially developed not for X-ray radiotherapy, but for particle radiotherapy, where motion management is very critical. But obviously, not everybody has particle therapy machines, so it got adopted in X-ray and it bloomed. So, so image-guided radiotherapy. Well, this is an attempt to minimize the setup margin, so less required setup margin. Started as a 2D matching using MV X-ray, so EPID images, then evolved to 3D matching, onboard matching, and real-time tracking, as we use now. So SRS, SBRT, SRT, all these techniques is realized with tighter margins. More dose to the tumor and less dose to the risk organs. Because when we increase the dose, especially the dose per fraction, often toxicities, especially late toxicities, worsen before you get a better local control or cancer control. So tight positioning is the key to SRS and SBRT. So started off as intracranial tumors using frames. Now we use respiratory gating and IGRT to treat other parts of the body, with, of course, some dedicated hardware. Okay, so particle radiotherapy, like protons and carbon ions, these uses ions instead of photons, resulting in a distinctive dose distribution. Started in the 1950s for ocular melanoma, which is really interesting, and used in other cancers from the 1980s. The downside of this technique is it requires a huge accelerator. So this accelerator is rather old, so it's rather large, but it covers about 60 meters by 120 meters. So you have the injector, then the synchrotron to accelerate the particles, then to the treatment room. You get a very distinctive distribution like this, which you can't realize with photons. Okay, so IMRT, IMPT. Dose distribution comes first in IMRT and IMPT. Whereas beam setup comes first in normal forward planning. This is all realized by advanced information technology. So with forward planning, of course, you have the beam setup, then you have the dose deposition calculation. Whereas in inverse planning, you have the desired dose distribution, then the beam data is created from that, resulting in a very distinctive dose distribution like this, or like this. So does all these techniques make a difference? Is it worth it? Well, meta-analysis shows that it shows the superiority of IMRT over CRT or 3D CRT in efficacy. We're talking about efficacy here. Yeah. SRT to be superior in overall survival for stage 1 non-small cell lung cancers, and improved quality of life for brain metastasis is suggested. So yes, it's worth it. But how do we evaluate this? Well, quality adjusted life year or QALY is widely used as a cost-effective studies. WHO recommends up to three times of GDP per capita for one QALY. So I looked up the Bangladesh GDP per capita in 2024, and IMF says it's 2,600 US dollars. And yes, it has been stagnated for this 3 years because of COVID and many other reasons. But before that, there was a spectacular but sustained growth of over 10% per year. Well, we cannot put a price tag on our patients' well-being, but since resources are limited, well, the maximum acceptable cost would be around 8K to 12K US dollars per QALY in the current setting, I would say, in Bangladesh. But this will obviously change dramatically over the next 10 years. It will be projected to be over 6,000 US dollars per GDP per capita in 10 years. So that would obviously change. So how much does IMRT cost? IMRT over 3D CRT is estimated to be $4,000 to $5,000 per QALY in head and neck cancers. So the answer is quite simple. Yes, IMRT is effective, and it is cost effective. SRS to be par with VATS in cost and outcome. So you can do surgery if you want, and you can do SRS if you want. SRS for oligometastatic tumors is estimated to be 20 to 40K US dollars per QALY. So this starts to become a little bit questionable, but still doable. How about particle therapy? Probably the short answer will be no, it's not cost effective enough, except for one exception: pediatric tumors. Pediatric tumors have a reverse cost, meaning that the reduced toxicity, the reduced late toxicity leads to better quality of life and less required healthcare. And this is just talking about healthcare, required healthcare itself. We're not talking about the lost or earned prosperity because of the improved quality of life. So yes. Other sites, studies show a rather high cost per QALY. So, so IMRT seems to be affordable and feasible at the current day. So SRT, a little bit controversial, especially when using dedicated machines like CyberKnife, etc. Particle therapy is generally more expensive and more not cost efficient, but the exception would be selected pediatric patients. Obviously, you have 170 million people here in Bangladesh in a rather tight area. So it does make sense to have a pediatric center with particles therapy capability, probably protons. As worse. So high precision radiotherapy is a required technique in today's patient care that doesn't necessarily require expensive equipment. High precision radiotherapy can be only done with proper knowledge and uncertainties in radiotherapy planning. As I said earlier, we are cutting down all the margins. So we are cutting down all the safety margins to realize this technique. Of course, we alleviate that with newer technology, but at the end of the day, it is how much we, the healthcare providers, are cautious enough. Lack of attention to detail will result in worse outcomes. So, more toxicities, less local control, which we all don't want. So, that's about it for me. Thank you.